Hello everyone and welcome to today's event, Digital Transformation in the Age of Covid-19, Quality Standards and Inclusive Solutions in Digital Health. I'm Pritesh Mistry, Digital Fellow at the King's Fund. I'll be your host and chair for this event. We're joined by a fantastic panel including healthcare professionals, patients and digital transformation experts. So to start off with, I'd like to introduce each of our panel members, or invite each of our panel members to introduce themselves in alphabetical order. So starting with Amber, please could you tell us a little bit more about you and your background?
Okay, I'm Anba Subramanian. I'm a consultant physician retired from the NHS. I specialize in spinal cord injury rehabilitation and brain injury rehabilitation. I'm presently Group Medical Director at Renouveau Care, which is 2 rehabilitation sites, one in South Newton in Salisbury, the other one in Hollenden Park in Kent. They specialize as well in the rehabilitation of acquired brain injury and spinal cord injury. In addition to that, that's why I use technology. I provide medical legal reports for catastrophic injuries to the courts. And during the pandemic, this has been a lifesaver for me, the use of technology, and I will mention about this later on.
Excellent, thank you. Harpreet.
Thank you, Pritesh, and great to be here this morning. So I'm Harpreet. I'm a GP in London, working in North Central London, so in an inner city practice. My background essentially is bringing informatics and healthcare technology in and thinking about how do we reshape and redesign healthcare with technology-enabled services, essentially. Prior to my current work, I was the Associate Chief Clinical Information Officer at NHS England. And so a lot of my time there was thinking about how do we bring the clinical insight into healthcare redesign enabled by technology and develop new models of care. I'm currently also the board member of Health Education England, and there a lot of my work is understanding on new skills, new education and training for our workforce, in particular thinking about data, digital and innovation. Look forward to the discussions this morning.
Great, thank you, Harpreet. Michael.
Okay, so thanks, Pritesh. My name is Michael Oliver. My professional background is in podiatry, and I was a clinical lead in the podiatry service for about 6 years. Although currently I'm working as a project support manager for Live Well South West, and I've been leading on various digital transformation projects across the organisation. So Live Well South West is a large citizen enterprise delivering integrated health and social care across Plymouth, South Hams and West Devon, and we employ just over 3,000 people.
Thank you, Michael. Tina.
Hi, thanks Pritesh. My name is Tina Marshall and I'm the UK Country Manager for Visiva Care. We've been doing this virtual consultations for over 6 years now, offering our customers a white label solution, and the quality of how you can do it is really something that you learn over time with some small tips and tricks. For us, scaling in COVID meant that we launched 512 clinics within 4 weeks, while still retaining a 98% patient satisfaction rate, 99.9% uptime, which is really impressive, I think. And also we managed to reduce the DNAs to 2% for our patient-initiated meetings. So all of that comes with the experience that we have to bring a quality solution to the market. And hopefully we'll be able to discuss that more today.
Thanks. And Victoria.
Hi, Pritesh. My name's Victoria Holton. In 2002, I was in Spain for a long weekend and I had a skydiving accident. I landed on my feet, fell over and broke C5, the 5th bone down in my neck. As a result, it damaged the spinal cord and I am paralysed from below my shoulders down. So basically the bits that work on me are my head, my neck, my shoulders, and I've got muscles on the inside of my arms that work, but I'm unable to use my hands. As a result of this, I spent 18 months in a spinal unit back in the UK, and I get ongoing care from that spinal unit with annual updates and reviews. I use digital technology in lots of parts of my life, and I am keen to see and explore further how digital technology can help me with my healthcare.
Great, thank you. And thanks to everyone on our panel for joining us today. Fantastic expertise and really looking forward to the discussion. I'd also like to thank our event sponsor, VisibaCare. We are recording this ahead of time. When registering, you'll have had the opportunity to provide us with a list of questions. I'd also like to invite you to submit more questions via Slido. You should be able to see the Slido interface in the box next to the video, and this is where you can submit your questions. Our panel will be able to respond to the questions during the event. Also during the event, we're keen to hear your opinions as well. So you'll occasionally see some poll questions appear in that Slido box to the right of your video during the session. If you're tweeting, please use the hashtag KFOnline. And finally, to the right of the video is also the resource tab where you'll find additional material for you to read through. So in today's event, we're discussing the digital transformation that has occurred as a response to the novel coronavirus. Each of our panel members has had a slightly different perspective and experience of the digital transformation during the pandemic and the new reality we now occupy. Digital solutions have taken centre stage as the main mode of healthcare delivery. To do so has required rapid digital transformation, enabled not just by technologies, but staff, patient involvement, and protocol changes. To start the discussion, I'd like to ask each of the panel members to answer the following question. How has the digital transformation as a response to COVID impacted your experience of health and care? So to start with, Amber, if I could ask you to answer that question, please.
I've been involved in research on digital health, I would say pompously, ahead of my time, because it was in 2003 that we started our research, and we published in 2008 on a randomized controlled trial on following patients with spinal cord injury with or without telemedicine, as it was called then. So we knew that we would not be able to cope with the number of patients that come through our doors and offer what we wanted to offer. It's a service from injury to grave. So that was why we teamed up with two other units from across Europe. We got some European funding, and that was the start of our research involvement. So during the pandemic, things have moved on quite quickly, because all of a sudden, things that were not possible before became possible straight away. As I said earlier, I work as a consultant in a major rehabilitation unit, and I do medical legal work. So I have to visit and examine patients in their own homes and provide the report. So it has to be reliable. I told myself the same question when technology arose and I was faced with sort of the new venture. Said that if I use technology, it has to be a quality of care that is at least as good as face-to-face, because I knew that there would be resistance from a lot of quarters regarding the use of technology, not least from my own fellow clinicians and consultants in my field of expertise, because people will always believe that you can't do anything without sort of face-to-face. Yet there are many aspects that I can challenge there, but that maybe would be a debate for another day.
Thank you, Amber. Some very interesting reflections there, which we'll dig into in further down in the discussion. If I could move on to Harpreet, what's been your experience of the digital transformation?
Thanks, Pritesh. I mean, look, it's you know, reflecting on what Amber's just said and thinking through my work. I mean, back in 2016, we started on the journey, and prior to that, in the NHS, in how do we think about digital first primary care? How do we think about actually get the NHS starting more digitized? And up until probably the end of 2019, we probably had around 5% of all practices across the NHS England offering remote consultations. In my practice, I think I was probably that less, probably around the 3% mark. So at around 30 to 35 consultations a day, I was probably doing 4 telephones and 1 home visit. The rest all face-to-face consultations. Fast forward March 2020, that's gone from 5% to over 95% of my consultations done remotely. Vast majority done on the phone, but a small proportion done on the video, and even much more small proportion, if rarely now, done from home visits. So you can see the game-changing speed that we've gone from one extreme to another. Now, some would say brilliant, some would say fantastic, some would say that's exactly what we wanted, but we have to think about this in the context of the different types of people and patients that are coming to access care for us. You know, not everyone is always tech savvy, not everyone has good connectivity, not everyone has Wi-Fi, not everyone has 3G, 4G. And some of my population, where I work in particular, in the South Asian where I'm in the city, it was actually quite eye-opening, because when speaking to some of my patients, a lot of them felt that actually they didn't want to use the limited data they had in consulting with their doctor on a virtual consultation, because that data that they have is quite expensive, and they want to use that to talk to their families abroad rather than using it and hanging out with their GP online. So I think we need to reflect here on who does this really work for and how does this work best. And I think for me, in particular, as we've gone from that kind of less than 5% to 90%, more than 90%, sorry, what we've done is that we've missed that tremendous amount of learning in between. What are the use cases? You know, who does this work for best? What types of patients really actually benefit from this? And it was quite ironic, actually, because prior to all of this, we all felt that actually the most easiest potentially speciality that we could use remote consultation with is dermatology. But actually what it's come to show is that dermatology is proven to be the more difficult speciality, because not everyone has a good camera on their phone, not people have good enough light, some people hold the rash too close to their bodies, some are like holding it in different ways. And what we've done eventually is got them to email the pictures to us, which has been beneficial, but ultimately, in my practice in particular, we felt like by bringing patients in, we can diagnose skin conditions better. So that's an example of how we may hypothesize one thing, but actually in reality and in practice, things play out to be much different. So that's kind of the care delivery aspect to it. But in terms of other game-changing things, we've seen is that the way our clinicians work has considerably changed. So actually, I think that clinicians are probably working at greater to the top of their license. And what I mean by that is a lot less time spent on administration tasks or running around, actually a lot more time focusing on the patient and what their needs are, because then you can triage effectively and you can really bring those patients in that need the support and the help. And I think that's been really game-changing. I think it's also been a game-changing aspect for many of our practice administration staff, so that they can triage effectively, but also point patients to the right direction, rather than have a whole host of people turn up at 8 o'clock in the morning to try and get an appointment. This is a way for many of them to get different blocks of appointments throughout the day and be a lot more flexible to when it's convenient for the patient. And for the patient, ultimately, there's been a great amount of access, convenience, and benefit. So even though all of this sounds exciting, the key thing missing in all of this, which will need a lot more work, is evaluation and creating evidence. Is that actually, even though we fast track, you know, in the space of weeks, what we would have done probably about 5 years, we need to pause a bit, think about what actually works, generate the evidence, and really understand, is this cost effective for the system? And for me, those are some of the key learnings that I felt have come out of this. But I'm very excited moving forward in this, because I think much of this is here to stay.
Excellent, thank you, Harpreet. So yeah, it sounds like access has changed dramatically for the better for some people, and maybe worse off for others. And some of the learning that we would have otherwise have gathered may have been lost because of the rapid transformation that's happened. But there's still a need to evaluate these tools and see where they will benefit patients and our communities. Thank you. Michael, if I could ask you to reflect on your journey so far.
Yes, certainly. So, as I mentioned in my introduction, so we're slightly ahead of the curve in that we'd recognise the sort of need for virtual consultations. But what we found is that it's been a very slow process to get from the fact that's the point from where we had a platform to actually getting our staff to deliver those virtual consultations. But what COVID has done, and echoing some of the comments made by Harpreet there as well, is we've done years worth of transformation within a few months, and we've given so many of our staff the opportunity to actually have a look at have a look at digital consultation platforms and how they could use it. And what we find is that once staff start thinking about about virtual consultations, they start to get more and more ideas as to how they could use them within their practice. And we've got some really very innovative staff within our organisation that have really tried to push the boundaries of what they're doing and try to challenge the sort of normal status quo of how we're delivering care. So I think we've seen some really good results of that. And and we had some services during a COVID period, like our children's speech and language. They've gone from delivering 0 consultations prior to COVID now to 90% of their work is been done virtually, which has been an absolutely amazing transformation. But I'd say it's not been an easy process to get through, and it's been challenging for staff. It's been challenging for patients as well. I think when I get into the stage where I said we need to build on some of the learning and really look at the pathways of care that we're delivering, because what we find is that some areas are very quick to say, well, virtual consultations won't work for us because we deliver hands-on care. But what we're finding is when you start to break the pathways down, right from the point of referral through to the point of discharge, that there's lots of opportunities to convert different bits of that pathway to virtual care, but still recognising the fact that there will be times where we need to see patients face to face as well. So it's just breaking that down into smaller elements and working out what's safe to deliver virtually and what still needs to be delivered face to face.
Thank you, Michael. It sounds like digital isn't something we can just add on, and we need to reconsider our pathways as well. Thank you. Tina.
Hi, thanks. It's really interesting actually to hear all of you speak. So I'm in the fortunate position where we do have the heritage in Sweden of bringing the transformation, and we do have the use cases and the evidence to see where it's worked. I think choice is really important, and I think it's really important when we're looking at digital transformation that for all of us that we understand it's more than a video consultation. There's Skype, and that's been around for donkey's years. But digital transformation is more than that, and it is about how can we impact the patient pathways, how can we increase value and efficiency and deliver those savings whilst making sure that the patient care is never compromised. So I think it's really, really interesting.
Thank you, Tina. There's a lot of expertise in industry that brings a lot of experience into digital transformation to the table as well. It's great to hear. Vicky.
Hi. I began the lockdown period with no food deliveries, so contacted my GP. I didn't expect a same-day response, but very quickly I got a response and was very quickly added to a shielding list, and as a result was able to access my usual supermarket delivery and was able to get food, so that was great. Another way I found that communication was much better was I started getting weekly calls from my CCG, Care Commissioning Group. I've never had those before, but they were keen to make sure that the pandemic wasn't affecting my care. So that was also great. My annual review at the spinal unit also came up during that time, and I think unless my situation had been particularly critical, I would have been unwilling to go into the spinal centre and have a face-to-face consultation, mainly because my chest muscles don't work, and so my breathing is compromised, and if I do catch COVID, then I'm at great risk of not surviving it. So obviously being shielded and staying away from people was really important to me. So I had my update with my consultant by phone. We were able to make a suspected diagnosis, and I had follow-up X-ray and ultrasound as a result. That was organised very swiftly, and it seemed very much more efficient than usual. And we were able, within 48 hours of having the tests, to confirm the diagnosis and agree the next steps. So all in all, I found it a very easy, very efficient service. So a good response from me.
Thank you, Vicky. It sounds like you've really appreciated some of the changes in the digital transformation.
Yeah.
And especially when there's a high level of unpredictability, I think maintaining communication in a way that digital allows can really support an improvement in experience of your care as well. So let's dig in a bit deeper on some of the comments that have been made so far. It'd be very interesting to understand how the rapid digitalization has possibly impacted the quality and the standard of care. So Harpreet, if I could ask you, in your perception, how has this rapid digitalization impacted quality and standard of care?
It's a good question, Pritesh, and I've been thinking about this quite a lot recently. I mean, if you look at some of the dimensions of quality and we think of access and experience, let's say, I think it probably has improved some of that for a whole host of patients, but not for everyone. And I think there's probably a reason for that, and I articulated those earlier. If we think about safety, again, it's still debatable because, and let me explain what I mean by that. As a GP, my job is to manage the risk of my patients and manage the uncertainty that I have with my patients. And what we're facing is that through telephone or video, you can't often interact or examine or get that verbal cues or all those different cues that you get when you see patients face to face, often from a telephone or virtual. And so the practice of care becomes different. You become more defensive, you take less risk. And so what ends up happening, and this has happened at the start especially, but now it's got better, is that you end up getting a much lower threshold when you're prescribing certain medications. So in the case of some of the patients, for example, many of them are probably getting antibiotics that may have not needed antibiotics if they'd come to see us and we had done a proper assessment, we had done a full examination, we had done their observations and got the temperature. But because it was all virtual, it was done through telephone or video, some of them may have got the antibiotics they may not need it. And so for me, that is a slightly lower quality of care because essentially, again, antibiotics are not necessary for everyone, but for those that need it, we obviously give it. But again, with the infrastructure that we had, it was how we had to respond at the time. Now, what we've been doing since then, and this is where the systems, really come through together as a whole. The academic, some of the evidence has come through. We've developed risk assessment scores. We've developed a much better understanding and working with industry as well of how we can effectively do remote consultations, how we can use video and telephone, and how we can even set people up in their own homes to manage their observations. Now, again, as an example, I know NHS England went out and bought a few 100,000 oximeters to distribute to the more vulnerable populations in certain population groups. Now, that is a good step. But again, it's not at this point accessible to everyone. So the question arises, if we are really looking to develop a new standard of care and raise the benchmark for everyone, as per the values of the NHS, we have to make it equitable and accessible to all. And I still think we've got quite a bit of way to go for that to happen. But even talking to some of my patients about the access and experience part of it, if we're again touching on that, for them it's been much more convenient, especially the slightly younger demographic. So those that don't often have to leave work early, those that can, for example, dial in first thing in the morning or later in the evening. And I think for physicians as well, in my case, I've had the opportunity to consult from home. And if we look at that from the quality perspective from the physician and the clinicians, I think that's also raised the standard. And I think that will ensure that the flexibility that we've brought to the way we practice now, for many, it's here to stay. And many now want to build new cares or working new pathways that factor in the role of technology a lot more. And I think the most interesting observation through the quality and standards piece is that is how we are using the NICE guidelines that have been created. And I know some of them have also been revamped in terms of helping us make better clinical decisions. So on the whole, I think it was a slightly patchy start, but I think we've got to a place now where actually the quality and standard is probably quite consistent. But like my point at the start, we still need a lot more evidence evaluation to really determine that is this actually improving patient outcomes and is it a better service compared to the counterfactual.
Great, thank you, Humphrey. Interesting comments on this bumpy start, and I wonder if things have changed in that kind of duration as people have got more used to video consultation and the role of training within part of that?
Yeah, I think so. And sorry, I was just going to say one thing is that, at the start, we also didn't know what COVID was. Everyone was kind of figuring that out, and everyone who presented in lots of different ways would have had COVID because it had so many reverberations. And I think that's an interesting dynamic that's now much improved.
Great, thank you. And just one more comment before I come to you, Amber. I think also there's a perception of what we define as quality. So quality to, as you mentioned, rapid access to a patient might be quality, and whereas for a clinician it's the safety and maybe the overdiagnosis or underdiagnosis elements as well. Thank you. Amber.
No, I just wanted to pick up on the point that has just been made about the care at the GP surgery. I've been using the GP surgeries for many, many years, and at times, unfortunately, no fault of the GPs, they are stretched. They have to do a very quick examination, and they do not have the time to be able to go always into all the clinical examination that we have been taught at medical schools. So what I have felt using digital health is that this can provide us with a fantastic triage opportunity so that the GPs can then look at what is essential from the triage system. So I feel that this would help us to avoid having unnecessary antibiotics, which at times are also prescribed unnecessarily, even at the GP surgery.
Excellent, thank you, Amber. And if I could bring Michael in, could you please comment on how you feel the rapid digitalization has impacted the quality and the standards of care?
Yes, certainly. So let's say within our organisation, we've made some great strides and achieved lots of really good things throughout the COVID period. But let's say if we continue at the pace that we've developed this offer, then we're in danger of leaving people behind. And when I say that goes as much for our staff as for our patients as well. But there's been lots of challenges that we've been through around the sort of technological ability of our staff. Some have taken to different virtual consultations like ducks to water, but for other people it's been quite a scary thing. And then when you put that against a backdrop of people working in potentially in different roles to what they used to because of COVID, not able to see the patients that they feel that they need to be able to see, then that's just added an extra layer of challenge into it as well. We've sort of recognised as well that the sort of infrastructure that we've been trying to use as well hasn't always been up to the task. And so for example, some of our laptops didn't have sufficient amount of memory in them to actually deliver a proper video consultation. So what staff are finding is when they're already quite stressed out with having to deliver care in a different way, they're finding that the platforms were perhaps a bit glitchy. There's a bit of delay on sound, and that's again just because our actual infrastructure wasn't geared up for delivering this. So I mentioned the sort of quality of the laptops, but even just bandwidth on VPNs for staff who are working at home, that was quite limited again, and that was potentially having an effect on staff's ability to deliver consultations. Some are obviously able to overcome that quickly, but for others, that's going to be something that's going to really put people off at a really early stage. And then trying to get them back to delivering this sort of care in this way, but that's certainly can be a challenge as well. And then building on what Harpreet said as well, lots of patients as well are in exactly the same position, find technology really difficult to use. We're getting them to download things we've never asked them to do before, and that just adds a whole layer of challenge to the interaction. And then what we find is that some of our clinicians have spent some of their clinical time helping staff to use the technology instead of actually being there helping patients to use the technology rather, instead of actually delivering the care that they want to deliver.
Great, thank you, Michael. I think we'll touch on the digital divide further on in the discussion. Just reflecting on what you mentioned around infrastructure, I think that there's the aspiration of video consultations, but some of the complexity in the connectivity and some of the infrastructure issues means that you start dropping down to telephone, and that's what you've got to rely on. So I think there is something definitely about reliability, and Tina, I was very interested to hear your comment about the Receiver's reliability. Is there anything you'd like to add?
Can I?
Oh, of course.
Of course. I was saying earlier in my introduction that my commitment in using technology is to make sure that it would end up offering at least the same quality of care as face-to-face. With regards to all the very valid points that have been made about technology and the problems that people face when using technology, I would say that the bottom line would be to employ a technician or somebody, a computer specialist, etc., to be able to help us. And I've done that in a research project successfully. Technology, for me, has made people more innovative. And in my field of expertise, which is spinal cord injury, brain injury rehabilitation, many of my patients are in wheelchairs. So, at times so I've been able to examine them in wheelchair or whilst walking, in the bed, because at times there's spasm, which for those of you familiar with spinal cord injury, etc., the spasm may be more important in the morning or in the evening. So we can then schedule, which I've done, a time to examine them at different times of the day to capture the spasticity that is not always obvious, and then asking them at different times of the day would allow us to examine them without having to ask them in a consultation to transfer. At times they need a hoist to transfer. We can examine the muscle power, range of movement, and I'm hoping that there are some limitations I don't deny with regards to range of movement, etc. But we are hoping that with artificial intelligence engineers, we'll be able to move the goalpost further. And last point, I would say that for many of our patients who face issues with mood, I've found that technology has been a very useful tool to help us capture the mood and also to allow us to offer psychological support remotely.
Excellent, thank you. So it's very interesting to hear these kind of reflections from everyone. I think we'd all agree that the individual and the patient should remain centre of the care that we provide. Previously, before COVID, the NHS long-term plan had a very strong strand around person-centred care. So it'd be great to hear from some of our panel members on how the digital transformation has potentially impacted person-centred care. So Vicky, if I could ask you to reflect on some of the changes and how it's incorporated you and empowered you to be more involved in your care.
Thanks, Pritesh. I am a member of a group on Facebook, and there are about 2,400 of us with spinal cord injuries. So in preparation for this, I asked some of them to give me their experience as well, so that I'm talking not only about my own, and just ask them how in lockdown they found their consultations and whether digital health had played a part. On the whole, the results were overwhelmingly positive. People talked about how easy it was to get an appointment and how efficient it was, that they were able to potentially speak to somebody in the morning, get treatment, antibiotics, whatever, in the afternoon, and actually get a really quick resolution to their problems. The majority of people seem to have telephone consultations. A few of them had video calls as well as backup, and some, like myself, did have to venture out into the hospital to get some more technical tests done that couldn't be done virtually. There were a lot of people who talked about the convenience as well, not being needed to have to sort of get up in the morning super early, and some people can't do that because with spinal cord injury they need help to get up, and that may be delivered by a community nurse or a team of carers who come in from the outside. So that's difficult, and then they have an appointment that is potentially quite close to their getting up time. Then there's the stress of getting there, panic of can I find a disabled space and park up and get there on time. So all of that was overcome just by needing to get to a telephone or be able to be looked at in your own home. there are only 11 spinal units that are specialist units in the country, so they cover quite a big region as well. And as a result, you find that potentially people are travelling 3 or 4 hours each way to go to an appointment at a spinal unit face to face. And that was really, really appreciated, especially if the first call could be virtual. It saved them all those hours of travel. There was one person who said it took them 4 taxis, 2 train rides, and money, the expense, the exhaustion, and they got a 20-minute consultation, potentially then being told, oh, you need more follow-up tests, so come back on another day. So they had to repeat all of that as well. Somebody talked about environmentally how it was also good because, you know, all that travel they didn't need to do. So that was also another positive. There were a few negatives that came up. One person had missed their video call because their internet was down. One person had an incredibly frustrating tale where they had to email their GP. Their diagnosis was made from their email. They got a text the next day saying, go and pick up some antibiotics. They felt that the diagnosis wasn't correct, or that the information in their email had been misinterpreted. And so as a result, they tried to get in contact, but they found it almost impossible to actually speak to a human being. And that, I think, is probably the crux of where the system potentially will fall down if we can't get to talk to human beings. So I think that 99% of the feedback that was received was positive, although, of course, the people I'm talking to via technology are obviously very comfortable with technology, and therefore probably my results are a little skewed anyway.
Thank you, Vicky. That's really interesting. It's good to reflect on both the positives and the potential negatives of the technology and where it can potentially improve or continue to improve as well. Harpreet, if I could bring you into the conversation as well. Just as you mentioned, there's particular segments within your communities for which technology will work and technology won't work. So if you could perhaps explore that a bit further and how technology may enable a more person-centered care approach.
Yeah, no, absolutely. So, I mean, I guess the challenge I face when thinking through this and how do we actually make this more beneficial for our patients is that what essentially we've done at this point is just provided an additional platform or medium to consult with our patients. So, you know, historically we would do telephone, email, text messages. Now we have the opportunity to do video. What we haven't done is fundamentally change the whole pathway of how people are accessing care and actually the whole end-to-end. And so what I mean by that is that everything else pretty much, apart from the fact that you have to meet a GP, is the same. The way they get their labs, the way they get their diagnostics, the way they get their medicines. Now, if we were really thinking about truly transforming patient care, we need to take the whole pathway and think about how can we redesign the whole pathway from end to end and with the enablement of technology. And so what I mean by that is, right, rather than the patient coming in and having a virtual consult, but then having to go to the local hospital to get bloods, why aren't we setting up more community diagnostic centres in the community to make it easier for people to access these close to their homes or near the GP surgery? Why aren't we getting pharmacies to deliver medicines to people's homes? You know, again, it's a new way of thinking, it's a new model, but that for me becomes truly transformational in terms of how we make it more patient-centered. By just putting on an extra platform, an extra medium to consult with your patients, for me, honestly speaking, is not revolutionary in terms of patient-centered care. It's convenient, it's accessible, but like Vicky was saying, it's not for everyone, and I think we have to be really careful of that. But again, the point I was making earlier is, you know, the flexibility of appointments, I think, for patients has been tremendous. You know, prior to this, the reports were coming through thick and fast that, you know, 3 out of 5 people or 4 out of 5 people cannot access a GP appointment when they want it or where they want it. And now what this has opportunities provided us to do is given people the flexibility to do that. And so, yes, that's a great step. But if we're really serious about patient-centered care, And we really need to think deeply, especially in the primary care setting, how we are going to do things differently. I think we need to think deeper. In the secondary care, I think it's actually even more of a game changer than primary care, because primary care has been digitized for a number of years. We've been doing telephone consultations for a very long time, whereas in secondary care, it's only starting to get a bit of traction now. And I think that's where the environmental benefits are great. That's where actually people having not to worry about, car parking or having to get the transport to the local hospital, all these things. I think it's quite a nerve-wracking experience for many of our patients, or even the expensive hospital parking fees that they have to pay. And if we can do follow-up appointments virtually, I think that is really beneficial. And I know colleagues working in secondary care and we've spoken about it here today. For them, this has been really, really important. And I personally had family experiences where for my mother, we've had the opportunity to consult with her consultant virtually through a video consultation, and what would have been 4 hours taken out of her day has only been 20 minutes. And I think that is a really game changer in terms of patient-centered care.
Excellent, thank you, Harpreet. I think I completely agree. What we tend to find in different sectors is as it digitalizes, you see a replication of what you're doing in the physical medium, and then you start building upon that and thinking about what's the unique advantages that digital entail.
Can I just make one more point, if I may? Sorry, it's just come to me, is that I think the other challenge we have in healthcare in particular is that we have always this double running cost. So not only are we investing a great deal in technology and saying that technology matters, but we're also saying we need 50,000 more nurses and X thousand more GPs. What we're not doing deeply enough is thinking again, is how are we reallocating these tasks, how are we shifting the workload, how are we thinking about the skills that we need? Because again, that's where technology will really have an impact. Because at this point, it's just layering things on top of each other without thinking through how is this changing the way we practice.
Thank you, Harpreet. So it sounds like we're still early in the stages, so there is a replication within the digital medium, what's happening in the physical medium, and what we really need to start thinking about is the transformation part of digital transformation. Tina, I could ask you to explain.
Yeah, thanks. I think that, I completely agree with everything that you're saying, and I think that we need to recognise that this is change management in the same way that it would happen in any scenario. The digital transformation it's happened slightly, but it hasn't really happened. So, if we take a step back and think of it as change management using digital tools, and these are digital tools that are there to complement our healthcare professionals. They're not there to take anything away from professionals or from the patients, but it is change management that we're looking at, and it does take time. We're never going to be able to suddenly save lots of money for the NHS, but what we can do is we can redivert that money elsewhere so that we can provide more clinical hours that could be used to different things to increase that efficiency. But we do need to take that step back and see exactly what can we do in the patient care pathways to deliver that.
Can I'd like just to add as well that in tertiary care, I think we are not saying that all this has not been done in the past, but I think we have not been using all the text, telephone as efficiently as we should have done in the past. We are now introducing video, but I'm not focusing just on video. All I'm interested is to increase the opportunities for people to be seen whether it's face-to-face or via email or via telephone, but at least they're seen. But I would say, I've just published a paper on this, we've got just a small percentage of people who are seen regularly in their outpatient clinics, because we just do not have the human resources to be able to see all these people. For all the points that have just been made, we say we need so many more nurses, so many more doctors, but we need to see whether with the use of technology, we could not be diverting the funds or using the funds such that we will have a combination of everything, of virtual plus face-to-face contacts, which people crave at times. And at times it's not one instead of, it's in addition to. But on so many times, I've seen a patient coming to me from Devon and Cornwall, 4 hours and each way. They come to see me, and this because it's an annual checkup. I said everything is fine. Yes, everything is fine. Do you have anything, any medical problem? No, whatsoever. So then, okay, they go back without me having contributed anything to their journey. So it means that for me, that was a wasted trip, and would cost quite a lot of money as well.
Thank you, Amber. I think that really does reflect and reinforce some of the comments that Vicky made as well. Thank you. And so just kind of exploring some of these themes that we've seen coming up already in more depth. So the digital divide, there's potential for digital technologies, connectivity, maybe some of the sensors not being on your phone, like the image camera on your phone not being there or not being accessible, resulting in a disadvantage. So how do we enable digital care without creating a digital divide, which would result in the disadvantage becoming worse off? So if I could ask Amber, maybe you to start off this.
Okay. Thank you. I would say the first thing would be to make sure that the treatment is affordable, preferably delivered within the NHS framework, and use all the technologies available, depending on different modalities and depending on the level of connectivity, video at times, internet, text, telephone. I think it's about the pathway of care that all of us have been alluding to. I don't want my message to be that the video will solve everything. I think the video would be just a tool within a toolbox. And we probably will be we should be organizing outreach clinics nearer the home of patients with the use of digital health. And maybe patients, so I don't even know whether we should call them patients once they are no longer under the care of the NHS as such, but having acute care, maybe individuals living with a neurological condition would be more appropriate. So these individuals could reach consultants at the GP surgery if they do not have good connectivity. And so that's the way. We just need to be innovative. And I think we've got the last point I would say is that the tertiary care has got a responsibility towards training the people in secondary, primary care, and patients and their relatives, and vice versa. I'm not saying it's not a vertical training going from tertiary care down. I think we tertiary care will learn a lot as well from all the other partners. So it's a sort of a cross-fertilization and a horizontal sort of relationship.
Excellent, thank you. And Tina, I could ask if you've got any comments on the digital divide.
So for me, I think it's incredibly important that as a supplier, when we're looking at developing tools, that we capture the needs and the opinions and the insight of an entire range of the population. That we make sure that we can do that. So for us, we do. I think it's really important for all suppliers to do that, and I'm sure many of them do as well. I think it's important, as I keep going back to, that this has to be a choice. This has to be a choice for the patients and the healthcare professionals, and it's not going to be suitable for everybody in the whole of the UK. It's just simply not going to be, and I think there has to be an education around who it is suitable for and how we can do it. There are some things that I think need to be done for the infrastructure of the entire country, with regards to the internet. I mean, I could be sat at home, particularly on lockdown. I'm at home, my two boys are here on their tablets, my husband's also doing conference calls, and it's really difficult. It's really, really difficult. So how do we go about doing that? But like I say, we're at the beginning of the journey, and I think there's an awful lot of work to do, but it's heading in the right direction. And as long as we keep talking to each other, and consider all of the challenges that everybody is dealing with, then we will all be able to deliver solutions that can help, I believe.
Great, thank you. And so we'll move on to another question. So it'd be good to explore the concept of digital and continuity. So one of the things that we're quite keen to understand is how does digital transformation impact continuity? Is continuity still possible? And does technology enable or detract from continuity? Harpreet, if I could bring you on this one.
Yeah, I mean, in terms of continuity, I think so. I mean, again, if I use my examples over the last few months in particular, I've had the opportunity to follow up with my patients quite regularly. And in fact, it's so easy that we just book them in myself rather than having to go for the administration section. So on the basis of that, by giving patients the opportunity to follow up with me, I think has been, again, for those individuals that have been accessing consultations remotely, the continuity has been very good. I think those that struggle are the ones that require home visits or the ones that need us to see face to face, because there the resources are still very limited because of those who might be shielding, those who might be vulnerable, or those that can't come to the practice. And I think that's where some of the continuity falls. And I think for me, that's where it's been a challenge as an individual, because I'm not always necessarily working throughout the week, and sometimes I'm doing consultations from home now because the opportunity has given us for remote working. And I think based on that, it's not worked for everyone. But moving forward, I think what this provides us with is that, if we think about that redesign of our protocols, is that if practices, for example, in the GP setting, spend the morning effectively triaging the patients, going through the list, they can use the afternoon to bring those patients in that really need to be seen. And I think that's where you can have much longer appointment slots. You can spend 20 minutes per patient, or sometimes 30 minutes, where you can give them that in-depth consultation and ensure that there's continuity in the complex disease management. If we think about the chronic kidney disease patients or the complex diabetic patients, and I think that becomes a really interesting model that we should be exploring. The other thing that we're going to be seeing is, with the advent of primary care networks and thinking about new allied health professionals joining the community, such as pharmacists, such as physios, such as social prescribers, and in particular the pharmacists. I think when we think about the polypharmacy, thinking about medication adherence that requires continuity, a pharmacist could really play a really important role as a community pharmacist to help with that. So I think that we shouldn't be relying just on the GP here. And now, what this catalyst that we've had provides us is to really think about how can we design the care with a GP being part of the solution rather than being the only solution. And I think that will allow us to ensure that there is much greater level of continuity for our patients.
Excellent, thank you, Harpreet. So there's something there about digital plumbing to enable team cohesion and team approaches to care delivery. Amber, is there anything you'd like to add on this?
Continuity of care would be, for me, the ability to report, to see patients, if possible, everywhere and anywhere. So, and ensure that there's a seamless care within the teams. And I agree with this promotion of multidisciplinary working. It's not just relying just on the medics, but everybody else who can contribute to the care of the patients. And so that we can offer a seamless service from, as I said earlier, about the injury to grave concept. And I would like to be able to offer sort of psychological and follow-up support after discharge from tertiary care to individuals with neurological conditions as well. So I think but there's one thing that I'm keen on, if possible, is that patients own their records so that they are able to carry their records with them. How this will be done, it's probably easier said than done, but I think that's something that we need to work on, because it has happened with me that I've seen a patient out of hours and I've had no clue how they were treated before. They could not tell me what the diagnosis was. It would help if they were the owners of their records and they could pass it on to them. But that's something that, as I said, we need to work on.
Excellent, thank you, Amber. And Vicky, if I could bring you in on the continuity question as well.
Yeah, I mean, for me, it's a positive thing. Taking the lockdown as an example, I wouldn't have had my checkup had we not have had digital health to rely on. So as long as it's another tool in the toolkit. It seems to be beneficial in helping that continuity. And also, like Amber mentioned, multidisciplinary teams. So it is better to potentially get these people together and get an answer much quicker.
Great, thank you. We're coming to the end of our event. Sorry, Tina, if you'd like to come in.
Sorry, I just wanted to say, based on the words from Harpreet, Amber and Vicky, being able to deliver care that way, that's when we actually deliver true integrated care, is when we can do that with multidisciplinary team meetings, including the patient. That's your integrated care. Not sending them from one to another, but just bringing everybody together at the same time.
Yeah, that's a very good point. A joined up patient journey rather than a distributed experience.
I can say something there. In the spinal unit in which I was working, at times when the patient would come, in the past they would see only one member of the team, either the consultant and more now the nurse specialist or etc. But then if they needed to see a physio or an OT, etc., very often they will be asked to come another day. Another day, that means another 8 hours travel. So I think that by having sort of the ability to be able to speak to different people through a platform, the problems can be resolved now and, well, much easier. I would not say it can be resolved now and then, but can be resolved more efficiently.
Excellent, thank you. There's a real appetite to continue the discussion, but unfortunately we're running out of time. So thank you all for your responses and the very interesting discussion. Before we close the event, I'd like to invite each of you to share one reflection. So Vicky, maybe if I could start with you.
Yeah, I'm actually thinking, I wonder if with our aging population, how far ahead we're thinking about designing the system as well. We need to make sure it's future-proof as well as being a good reaction to the pandemic.
Thank you, Vicky. Tina.
Thanks. For me, I think we're actually on a really, really exciting journey for where we are now. There's still an awful lot of work to be done. We're at the start of the digital transformation, the change process. Vicky's absolutely right. We need to make sure that we can take patients with us, as I'm sure that we will do. So I think it's an exciting time for us.
Thank you. Michael.
Yes, so I think during the sort of COVID period, we didn't give people too much choice in the offer. But now, as things are going forward, I think people want to get back to some degree of normality. But I think equally we've got to keep up with the sort of momentum that we've developed over the COVID period. So I think we really need to, like say, look at the pathways that we're delivering, work out where is it most appropriate to deliver virtual care, and then support people and to bring people on this journey. So we make it more than just like a Skype consultation. Tina mentioned that we really start to bring in lots of the different functionalities and really sort of change the sort of care or the model of care that we're delivering.
Thank you, Michael. Harpreet.
For me, I think I'll just like to iterate on the point that technology is one thing, but we can't forget the people and the processes. And we need to think about how we're designing those processes, how we think about new skills, new training, new roles, because ultimately, as Vicky said, COVID will probably go away, but this digital dump will not. And if we don't think about this deeply enough now, we'll end up with just a sticky plaster that's not solving the real problems.
Thank you, Harpreet. Amber.
I will start by giving the example of one of my patients now, who's an individual who lives with a spinal cord injury in a nursing home. He told me that for 7 years that he has been in that nursing home, each time he had a medical problem, he had to go through the carer or the nurse, etc., who would express his problem to the GP. And very often all this got distorted because they didn't understand fully what his problems were. For the first time this last few weeks, he's been able to speak to the GP directly on the phone, thanks to COVID-19 to a certain extent. So I would say that I would like the system to be user-friendly. We should involve the patient. It should be for patients, with patients and by patients. And I would like to explore other opportunities as well. For example, if you, my patient, do not have the ability to use anything in their hands, etc., so they rely on voice activation technology. So that's also the case of people with brain injury and who at times do not have the ability to speak properly who's got aphasia. So these are the points that I would say that this is the beginning of the journey. I agree with everything that has been said. It's not the panacea, but I think we need to reflect together how we can use this technology so as to improve the lives of everybody, including the clinicians themselves.
Excellent. Thank you. So technology has a key role to play, and we've seen access change substantially due to the rapid digitalization. And perhaps we need to be a bit more deliberate about how and why we use technology to release the actual transformation that we want to see. So improving the resources, how they're allocated, and avoiding disadvantaging those at risk of worst health outcomes. Also considering the right pace and approaches that enable staff to feel comfortable with the new technologies and tools, taking maybe more of an iterative approach with training throughout. So I'd like to thank our speakers once again and our event sponsor, VersebaCare. So these discussions have given me a lot to consider, which hopefully will be reflected in some of our future activities in digital health. A recording will be available on our website for those who wish to watch on demand. So please do share a link to this event with your colleagues. I hope you've enjoyed the event. There's feedback questions at the bottom of your screen, so please do provide feedback. It does help us to improve our events. So thanks once again to everyone in the panel, our sponsor VersebaCare. I'm Pritesh Mistry. I hope to see you again soon, perhaps at our Digital Health and Care virtual conference in November. Thank you.